area is not supported by the tarsal substructure. So any force that displaces the eyelid from its strong attachments can cause a tear, and of course can lead to stenosis of the puncti and canaliculi and epiphyseal. Canalicular tears, they are more common in children and young adults, more common in boys, and they can be caused by any penetrating trauma, causing direct trauma to the area, or mostly the children come with the history of dog bites. It's very common in our area, and they can be a part of any extensive facial trauma after a roadside accident or any other trauma. The case of this was a case of a dog bite, and this was a case of pencil trauma to this area. Now, starting with the management, of course, the first aid will be given first, and the prophylaxis for the tetanus and rabies if the history of dog bite or a roadside accident is there. We have to establish the extent of the trauma so that we can decide what we have to do first. The adequate time for the care of the canalicular tears is between 24 to 38 hours, but some surgeons say that they have good results even after 72 hours. Decision about the anesthesia, of course, the local anesthesia is not good in this area because it will cause the swelling up of the build-up of the fluid in this area, and identification of the minute structures will be difficult. But in cases we are not able to give general anesthesia, we can always go for topical or local anesthesia. Magnification, we should always use the loops or the microscope for canalicular tear repair, and of course with a good illumination. A detailed examination of the globe is a must. Sometimes there is swelling and we are not able to see it, but when we are planning the surgery, even on the table, we should look at the globe. And if there is a globe trauma, then of course first should be repaired. There are multiple types of stents, which are being used for the canalicular tears. The most famous one is the mini Manoka. It's simple, it's easy to use, and commonly used for canalicular tears. Just we have to pass through the both of the proximal and distal part of the canaliculi, and then it's pulled so that the bulb is just flush with the canalicular opening. There are some bicanalicular stents, the Karopth, Ridline, and Kanika Lacrimal stent. Karopth is just like the one we use for closed intubation. It has bulbar ends, and of course we have to retrieve it from the nose. This is the picture how we introduce it and just retrieve it from the nose, and then we can close the lid. This was a bit difficult to understand. It has an introducer, and under the endoscopic guidance we have to introduce this there is a tubal part, there is a thick proline part, and there is a thin proline part. The proline is basically a guide to pass the tube ultimately into the, bring it into the nose. Canical Lacrimal stent is mostly used in, it's more stable, it's easy to use, and mostly used in stenosis of the canaliculi. Today I am going to talk about the pigtail repair of the canaliculi, because Guinea Manoka is not available over our like public sector situation. So this is a simple pigtail that's like this, and we just have to pass it through the opposite punctum, rotate. It has a bit of a learning curve, but it's easy. Just we have to rotate it and bring it out from the other side, the proximal part of the punctum, and just to make clear that how we have to identify the proximal torn part of the canaliculi. It's very important. It was discussed, I guess, in the previous conference. We can apply isonephrine eye drops or do some ice packing. It will show us a collagenous ring, which we call a calamaracine. Of course, we can inject saline impregnated fluorescein impregnated saline, air, or the viscoelastic into the opposite punctum, and from where it comes out is of course the proximal part of the canaliculus. This is what we are going to achieve. First of all, we have to pass the pigtail through the opposite punctum and retrieve it through the torn proximal part, and then we have to thread it with the proline, and then we have to take it back so that it threads the whole of the canalicular system. Then we can always pass the proline through a silicone tube, which is simple DCR tube, which is cut into approximate size, and then the lid is repaired as usual. This is a real life case. We can see the lower lid canalicular tear. First of all, we have to dilate the puncta, because for the pigtail to pass through it, it's a bit larger than the size of the punctum, so we have to dilate the torn canalicular part also, and we have to be very careful in this part, because we can always tear it through and cause more damage instead of helping it out. Again, the upper punctum should also be dilated, because we have to pass the pigtail through this thing, the upper part. Once the इसका cursor कहाँ से आएगा?
Pointer.
Okay. Proximal torn part. Initially, when I was learning, I used to pass the proline threaded through, and then I was like doing this sort of thing, like passing the proline through the silicone tube and then making it to pass through. But all this we can do. This is now we do. We initially pass the proline through the silicone tube, then pass it through the pigtail, and then we can the Polyflex helps very well, and this was told by my trainee, which I left the case with, and he's innovated this technique, and it's easier now. So again, when we are we have passed the silicone tube through the canalicular system, we can just tie it, and we have to bury the knot inside the silicone tube, and then we have to rotate it. So the final picture looks like this, like this thing we have applied a knot, we passed it through the, buried it under the silicone tube, and then rotated inside. And then the lid repair was done. The posterior part was repaired behind the tube, and the front part was repaired as normally we do. This was a simple case that we did at our center. Initially, when I was doing this, I was just passing the proline, but most of the children, because it doesn't seem good with the long thread hanging always over the face, and in kids there were a lot of cases of cheese wiring, so now we are doing it with the tube.